This eHIV review program is presented by DKB Med Radio.
Also, note that this is about practices and not labels. Some youth may have engaged in sex with other men, but don't label themselves as gay or bisexual. If you just ask, are you gay? You might miss that they are engaging with sex with men, but don't identify as gay. We also know from studies that creating a comfortable space for adolescents who have sex with men can increase sexual history accuracy and help better identify HIV risk factors, which can increase testing.
Youth and HIV, understanding the unique challenges. Welcome to eHIV Review. Youth, adolescents, teenagers, young adults, 13 to 24-year-olds. They think they're immortal. They feel they're invulnerable. And they believe they know everything. But they don't. Less than a quarter have ever had an HIV test. They account for nearly 1 in every 5 new HIV diagnoses in the U.S. Only 11% are on PrEP. What can their healthcare providers do to help them? What can they do to help themselves? To discuss these questions, we're joined today by Dr. David C. Griffith. He's an assistant professor of medicine and pediatrics at the Johns Hopkins University School of Medicine in Baltimore, as well as medical director of the Johns Hopkins HIV Service County Program, working with health departments across the state of Maryland. For our guest disclosure and additional CME information, please visit our website, ehivreview.org, and select the Volume 10, Issue 6 link. I'm Bob Busker, executive producer of DKB Med's e-literature review video programs. Dr. Griffith, thank you for joining us today.
Thank you for having me. It's a pleasure to be here.
Our overall learning objective for today's program is to assess strategies to improve outcomes for young people with exposure to or living with HIV. The learning objective focus of this first part of our conversation is to describe the process of obtaining a thorough sexual history to help evaluate an adolescent patient's risk for HIV, inform screening, and assess the potential role for HIV post-exposure prophylaxis, or as we all know, PrEP. That said, it's time to meet the patient. So if you would please, Dr. Griffith, take us to the clinic with a patient scenario.
So this patient is a 16-year-old male, is presenting for his annual wellness visit. He has no significant past medical history. He takes no medications, does not smoke, drink alcohol, or use drugs. When asked, he says he's attracted to both boys and girls. He's had some sexual experience with one prior partner. The partner was an older boy at his school. He's received and performed oral sex and has received anal sex on a few occasions. Condoms were used for some, but not all of the sexual encounters.
That seems to be a fairly detailed sexual history.
Yes, it is detailed. A common framework for sexual history is called the 5 Ps: partners, practices, protection from STI, past history of STI, and pregnancy intention. In this case, his partners, practices, and protection from STI were all discussed.
My question to you now is, how did all that information get revealed? We know that teenagers are notoriously reluctant to divulge personal information, particularly about their sex lives. And we also know that clinicians are notoriously challenged at getting teenagers to open up. And so I'm asking you this now in the context of what advice can you share with our learners who need to obtain a sexual history from an adolescent?
2 key things. Number 1 is to ask non-judgmental, open-ended questions. Very often, teenagers are quite relieved to be able to openly discuss their sex lives with a neutral, well-informed medical provider and get their questions answered. Our goal is to gain their trust so they have that opportunity. They may fear being judged, but your role as the provider is to let them know that you're not there to judge them, but to partner with them in their care.
Questions that are open-ended and non-judgmental. Give us some examples, if you would, please.
Let's say you want to find out who this patient had sex with. But you want to make sure you convey that you're not blaming or judging him. You could ask, how many people have you had sex with? Were they men, women, or both? Which may be too direct for an adolescent. To achieve that same goal, you could ease into it by asking, are you talking to anyone or seeing anyone right now?
talking to anyone. I'm not sure what that means.
This is a vague term, but I like to start vague and then get more specific to build rapport and ease into the conversation. For some, talking is just talking. Maybe they're communicating via text or via an app with a potential romantic partner. For other adolescents, talking may mean having sex. So after building some rapport and comfort, I always ask more specific questions and follow-up questions. I'll ask what gender the person is that they're talking to and ask if they're attracted to any other genders besides that gender. Then I ask, are you having sex with the person you're talking to? Often in this situation, the answer is no, but I always follow up by asking, are they having sex with anybody else? And that answer may be yes. So often they may be talking to one potential romantic partner, then they have a regular sexual partner that is not a romantic partner. And so you want to make sure that you're covering all your bases and understanding their full sexual history. And so I also then follow up with specific sexual practices. It helps if I explain why I'm asking. For example, I want to make sure I understand your sexual practice so I can give you the best possible care and keep you healthy. After this conversation, I always summarize what they've told me and circle back and repeat questions about sex and partners, sometimes in a different way before moving on. So you're talking to one person, but have not had sex with them, and you're having sex with one other person. No other partners, right? No other sex. I find it's easy for youth to answer after we've been on the topic for a bit, and sometimes the answer can change in the course of a conversation as they become more comfortable with me and talking about it.
Nice illustration of non-judgmental and open-ended questioning, Doctor. Thank you. But now, you said two things. What's the other one?
So number two is using terminology that adolescents are familiar with, not medical jargon. As I said earlier, I ask patients if they're talking to anyone. And like I said, this is vague and may mean different things for different patients, but I find it's a good starting point because it's a term they themselves use. From there, I can ask more specific questions about sexual practices and partners. Here's another example where open-ended questions come in. I might ask, what type of sex do you have? Often youth may need a bit more information, so I'll give some examples. Oral, vaginal, anal. For anal sex, I use the term top for insertive anal sex and bottom for receptive anal sex, and verse for when someone engages in both, because that's the term that many youth use. So I use them, the terms that they use. I'll say, are you top, bottom, or verse? I also preface these questions with an explanation about why I'm asking. As I mentioned earlier, it helps me understand what STI they may be at risk for and what tests we should do. Also, note that this is about practices and not labels. Some youth may have engaged in sex with other men, but don't label themselves as gay or bisexual. If you just ask, are you gay? You might miss that they are engaging with sex with men, but don't identify as gay. We also know from studies that creating a comfortable space for adolescents who have sex with men can increase sexual history accuracy and help better identify HIV risk factors, which can increase testing. Specifically, a study by Metesky et al. In Pediatrics showed that among adolescent men who have sex with men, only 29% were asked about their sexual orientation during medical visits, and only 21% had conversations with their healthcare provider about their sexual behavior with males. HIV testing rates were higher in those who had those conversations. This makes taking a good sexual history a crucial public health intervention.
Taking a good sexual history is a crucial public health intervention. Interesting observation, Dr. Griffith. So back to the patient we've been discussing. Talk to us about HIV testing. Is that indicated at this visit?
Yes, HIV testing is indicated. Both the USPSTF and CDC recommend routine HIV screening at least once for all adolescents. The CDC recommends testing starting at age 13, and the USPSTF recommends starting at age 15. Screening should start even younger if sexually active.
And that's a test everyone strategy, yes? Not just those with known HIV acquisition factors.
Correct. The guidelines recommend at least a one-time screen regardless of other factors. It is appropriate to make testing a part of routine visits for adolescents with annual testing. Men who have sex with men, youth with multiple partners, prior STIs, or youth on PrEP should have more frequent screening. Though we do our best to get an accurate sexual history, not all youth will be comfortable providing this information. So it's important to normalize testing for all youth, even if they deny sexual activity.
And this patient, the one we've been discussing.
Based on this patient's sexual history, in addition to HIV, you should be tested for syphilis, gonorrhea, and chlamydia. Syphilis is a blood test. Gonorrhea and chlamydia can be urine, as well as throat and rectal swabs. Many labs have validated self-swabs for rectal gonorrhea and chlamydia screening, which may be preferable to youth, provided they have no symptoms that require a direct exam. Often rectal and throat infections are without symptoms. CDC recommends STI testing every 3 to 6 months for men who have sex with men at risk for HIV acquisition.
And what about PrEP? In this first visit, is it appropriate to discuss PrEP?
Yes, a discussion about PrEP is certainly appropriate at this visit. The CDC recommends that PrEP should be discussed with all sexually active adolescents. One of the most important reasons is that PrEP is underused in young people. While youth account for percent, that's 1 in 5 of all new HIV diagnoses, only 15% of youth are PrEP users. Uptake is low, and persistence, meaning staying on PrEP, is even lower. Aside from becoming aware of the safety of PrEP provides, you should also know that PrEP can be prescribed as either daily oral pills or an every 2-month injection called cabotegravir, or an every 6-month injection called lenacapavir. Unfortunately, access to the long-acting injectable formulations can be limited. Youth may have different preferences. Some may want pills, some may prefer shots. They should understand that any provider, including pediatricians, can prescribe PrEP, and that if it's not covered by insurance, the drug manufacturers have payment assistance programs for qualifying patients.
What do you tell your adolescent patients about PrEP follow-up?
PrEP requires follow-up visits for HIV and STI testing. For patients on long-acting injectable cabotegravir, those follow-up visits for testing should be every 2 months, because that's the dosing interval of the injection. For patients on oral PrEP, follow-up visits should be every 3 months. Once lenacapavir becomes more available, presumably follow-up would be every 6 months. But I would argue that youth should be seen every 3 months for STI screening, even if not due for a dose. All this can be done with confidentiality, but requires care coordination.
Thank you, Dr. Griffith. Our learning focus for this part of our discussion is to describe the process of obtaining a thorough history to help evaluate an adolescent patient's risk for HIV, inform screening, and assess the potential role for PrEP. What are the most important things you'd want our learners to take back to their practices?
1. Creating a safe, non-judgmental space for adolescents is essential to obtaining an accurate sexual history. 2. Routine HIV testing should be done for all adolescents, with more frequent screening for adolescents with HIV risk factors, such as sex with multiple partners or partners with multiple partners, prior or current STI diagnoses, or youth on PrEP. 3. PrEP prescribed in a primary care setting, including by pediatricians, is an important tool to prevent HIV in adolescents.
Nice summation, Doctor. Thank you. And we'll return with Dr. David Griffith from the Johns Hopkins University School of Medicine in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's eHIV review program. Our guest is Dr. David C. Griffith, an assistant professor of medicine and pediatrics at the Johns Hopkins University School of Medicine in Baltimore. Our overall learning objective is to assess strategies to improve outcomes for young people with exposure to or living with HIV. In the first part of today's program, we discussed the process of obtaining a thorough history to help evaluate an adolescent patient's risk for HIV, inform screening, and assess the potential role for HIV PrEP. Let's look now at the second learning objective focus of today's program. Describe a strategy to communicate an initial positive HIV diagnosis to an adolescent, along with a proposed follow-up treatment plan. So, if you would please, Dr. Griffith, take us back to the clinic with another patient scenario.
So, a 17-year-old male presents to your office for routine follow-up. He underwent STI testing, including HIV, during his last visit 1 year ago. At that time, he reported sex with one male partner, and all tests were negative. He identifies as gay and is sexually active with men only. He reports 2 current partners. He says he is verse, practices both anal, receptive, and insertive sex. His condom use is inconsistent. He has no chronic medical issues, but notes a flu-like illness, fever, sore throat, fatigue, about 1 month ago that self-resolved. At this visit, STI testing, including extragenital gonorrhea and chlamydia testing, as well as HIV, are performed. His HIV test is positive.
Not all that long ago, a positive HIV screening result was tantamount to receiving a death sentence. Today, the original trauma of that early era has passed, in large part due to increased HIV education, as well as the incredible breakthroughs over the past few years, seen in ART, PrEP, and U equals U. However, among many, the fear and the stigma of HIV infection still remains. So here's your patient, 17 years old, who just found out he's HIV positive. How would you recommend a clinician approach giving a patient like this his diagnosis?
Whenever possible, it's ideal to give the diagnosis in person. If that's not possible, it's important to clarify at the time of testing how the patient wants to be contacted with the results, and then a follow-up appointment can be arranged. If the adolescent is okay with it, involving their parents can be very helpful to plan the next steps. One of the challenges is online patient portals. Convenient, yes, but often the patient will see the result before the physician does when it comes back, very often before the next appointment is scheduled. It's important to anticipate this. One way, actually an ideal way, is by establishing a follow-up plan at the time the testing is done. Overall, it's most important to encourage hope. We have excellent medications available, and when taken, most of the longer-term effects of HIV can be minimized.
Talk to us, if you would, please, about how to create a follow-up plan for a patient like this.
Firstly, it's good to start by letting them know that you know that they may be experiencing an entire range of feelings about this diagnosis and that you're there for them. I usually start by asking them what's going through their heads and just listening. I try to make a mental list of questions and uncertainties and fears that may emerge in the stream of consciousness and try to answer and address all of them by the end of the session. Often, adolescents don't have questions or don't quite know what to ask. So I usually start by reviewing the basics of HIV and HIV treatment. It's important to mention that this is an illness for which there are safe, tolerable, highly effective meds that allow you to live in your normal lifespan. If you stay on medicine with suppressed viral load, you can not pass your infection on to another person or to a future infant or child. Here is also a good time point to mention that there are many kinds of meds now, not just daily pills. I also let them know that there's good evidence that rapid initiation of antiretroviral therapy is helpful in improving patient outcomes. It's good to start meds as quickly as possible, the sooner the better, once the diagnosis is known. That helps with conveying a sense of the importance of lifelong treatment. I usually make a plan to see them again in a month and tell them that I expect their HIV viral load to have dropped by 90% in the first few days of treatment and by 99% in a month after starting. Lastly, I ask them to identify one person in their life who cares about them and can be a potential ally to whom it's safe to disclose their HIV status. There's evidence that disclosure to at least one trusted person improves treatment outcomes.
Adolescents newly diagnosed with HIV, where should they be referred?
Ideally, adolescents newly diagnosed with HIV should be referred to local clinics that have expertise in adolescent HIV. While these may not be available in all areas, it's important to identify local partners or champions. An HIV provider can be a primary care doctor or a pediatrician who has some expertise in treating HIV. In rural areas, it can often be a mobile health practitioner or a telemedicine provider. Local health departments can be a great resource. All these clinicians are potential PrEP prescribers as well and play an important role in preventing HIV in adolescents.
What are the most important considerations in caring for youth with HIV?
Adolescence is hard for everyone. It's a time of physical and emotional change, increased desire for independence, and competing priorities. Social priorities, school, family, sometimes a child of their own, work, etc. Adding a new diagnosis of HIV can make this time even more challenging. It's important for clinicians to ensure that patients are linked to HIV care and to support them until they are linked. Mental health resources may be useful in the short and long term. Support for adherence with frequent check-ins by call or text message can be helpful until a medication routine is established. Prescribing clinician and their staff need to be able to assist with navigating insurance and pharmacy issues, such as refills. As the MOCA study showed in virally suppressed youth, and the CROWN study is investigating in youth with adherence difficulties in viremia, long-acting antiretroviral therapy can be a viable strategy in adolescents with HIV to assist with adherence.
Talk to us, if you would, please, Dr. Griffith, about the barriers to retaining these young patients in care.
Evidence has shown that retention and care for adolescents with HIV is a challenge. Approximately 41% of HIV-infected youth are aware of their diagnosis, while only 62% of those diagnosed engage in medical care within the first 12 months of that diagnosis. Of the youth who initiate antiretroviral therapy, only 54% achieve viral suppression, and a further 57% are not retained in care. It's been estimated that less than 6% of youth living with HIV in the United States remain virally suppressed. Fortunately, there are many ways we can overcome these barriers. A multidisciplinary approach has proven to be effective, especially case management and mental health support. Studies have shown that getting input and buy-in from youth can help strengthen programs. Communication via text messages, the way that youth communicate, is also really important. Having a practice that is flexible and patient with adolescents can be really helpful as well.
What about the concept of differentiated service delivery? What do our learners need to know about that?
Differentiated service delivery is a responsive, client-centered approach that simplifies and adapts HIV services across the cascade to better serve individual needs and reduce unnecessary burdens of the health system.
Thank you, Dr. Griffith, for a very interesting conversation. Our learning focus for this part of our discussion is describe a strategy to communicate an initial positive HIV diagnosis to an adolescent, along with a proposed follow-up treatment plan. What are the most important things our learners need to do to best help a patient with a new HIV diagnosis?
1, having a plan for delivering HIV results and doing so in a controlled manner is important. 2, identify local resources for adolescent HIV treatment in your area to provide patient linkages. 3, overall, caring for adolescents with HIV requires meeting them where they are in terms of their ability to manage a chronic illness that continues to carry significant social stigma.
From the Departments of Medicine and Pediatrics at the Johns Hopkins University School of Medicine, Dr. David Griffith, thank you for sharing your knowledge and expertise with us in today's eHIV review program.
Thank you for having me. It's been a pleasure to be here.
For eHIV Review, I'm Bob Busker.